You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Here. So good morning, everyone. It's Chris Miller with Conferences Online in Allergy. It is August 22nd. Our first presentation today will be by Dr. Andrew White. Dr. White completed his allergy fellowship within the Scripps Healthcare System in California, and he remains in the Division of Allergy and Immunology at the same. He's a recognized expert in the diagnosis and management of Aspirin-Exacerbated Respiratory disease, and he's going to give us an update on that today. Thanks, Andrew, for being here.
Great, thanks so much. Sorry for the delay here. So I choose this slide when I give this talk because I really like the concept that AERD patients are just hanging out among us and they're sort of hidden because they by definition have nasal polyps and probably most of them have asthma. So it's really easy to give them those proper diagnoses, but maybe not take it quite to the next level. And they may also have AERD. And so we'll talk about, why that's important. I do have a lot of disclosures with a lot of the companies that work in the nasal polyp space. I'm just mentioning those here. And then our learning objectives, I want to hit on some of the current treatments. We'll talk about some of the unique aspects of AERD that may make it different from typical nasal polyps or asthma. And then talk a little bit about some of the things historically and maybe laboratory-wise that we can use to increase the likelihood of finding AERD. So I want to start with a patient. This is a 40-year-old female, had a history of recurrent nasal polyps and asthma. She had surgery twice in the last 6 years, and she was referred to me because her allergist had difficulty with polyp regrowth. And so she's actually now at the point where everyone thinks she probably needs another surgery. So this would be her third surgery in 6 years. She does tell you that she can't drink alcohol because of nasal congestion and asthma symptoms, but she takes NSAIDs without difficulty for joint pain. And so the question here is, does she have AERD? She certainly has some characteristics that would make you think that, but this question about the NSAID sort of would make you say, well, that's not possible that she would have AERD. Another question would be, could she have AERD? Maybe there's more to the story here that we're missing, and we're going to hit on that. You can tell I brought this up for a reason. And then maybe another important question is, does it matter? Now in the age with all the biologics, does it make a difference? And I'm hopefully going to try to make a case that it still matters to know whether or not she has AERD. So let's touch on just a couple introductory slides. So AERD, it's a chronic, almost universally eosinophilic rhinosinusitis. They all have nasal polyps, and almost all patients have asthma, although we definitely will see some patients where the asthma is a pretty minimal part of the disease. And the stereotypical reactions are going to be respiratory reactions, so rhinitis or asthma, when they have an NSAID or aspirin. And this is really a progressive disease. We still sometimes will hear patients being told that they really just need to avoid NSAIDs as one of their treatments to make their polyp disease better. And as we know, that's not true. This is a progressive disease, and the hallmark is that they react when they take an NSAID or aspirin. These patients are pretty stereotypical, so they often will present with the beginning of their respiratory illness in their 20s to 40s. Many of them will describe really completely normal respiratory health and then develop the progression, usually with nasal polyps and sinus disease first and anosmia, and then the asthma may come along a little bit later, but it doesn't always have to go in that order. The NSAID reactivity can occur anywhere along the time point. And one interesting observation that patients give, they feel like they had a viral illness when this started. And there's obviously no way to know for sure whether that was truly a virus, But about 50% of patients give this history where they were very well and healthy, they got sick, and they never ever felt better from that time point on. And some patients can even tell you, like, the week that happened, beginning of December 2019, I got sick, and ever since then I've lost my sense of smell and I've had these polyps. For the NSAID reactions, so this is a problem of COX-1 inhibition. It's not an IgE problem. The patients are going to react to anything that inhibits COX-1, cyclooxygenase 1, and that's the mechanism of action of NSAIDs. So any NSAID will do it. There's no need for sensitization, so the patient can have this happen on the first exposure. And because a COX-2 inhibitor is preferentially just a COX-2 inhibitor and minimal effect on COX-1, then these drugs are typically tolerated in patients with AERD. And for the US, we really have celecoxib and then low-dose meloxicam as the COX-2 inhibitors. Acetaminophen does have some COX-1 effect at high doses, around 1,000 milligrams. And so about a third of patients will actually react. It's usually milder reactions, but this shouldn't throw you off if a patient tells you that they have had a reaction to acetaminophen. So sometimes when I give this talk, I ask some of the attendees, if you had to pick the most important mediator or the most important cell in AERD, what would you pick? And some will pick the eosinophil, some would pick a mast cell, some may pick the ILC2 cell, which isn't depicted on this slide. Some may pick prostaglandin E2. So I think all those are right answers, but it's an interesting discussion because there's not necessarily one that rises to the surface as the true dominant mediator. But I do want to highlight a few things. So in AERD, prostaglandin E2 has a very strong anti-inflammatory role. It's preventing the activation of the cystinooleucotrienes. And for a variety of reasons, potentially, it's decreased in patients with AERD. They have a relative PGE2 deficiency. And when you take a COX-1 inhibitor, just the pharmacology is that you're going to decrease this further. And so this is probably a really important reason why patients end up with this big surge of leukotrienes, which you can see here on the right. Their prostaglandin E2 is inhibited by COX-1 inhibition. This causes significant upregulation of the cystinooleucotrienes. That's going to cause more airway inflammation. And downstream from that, you can get some alarmin activation like TSLP and IL-33. And further on down, you're going to start to see some of the real classic allergic T2 cytokines, histamine, PGD2, et cetera. And these also clearly have their own effects. A couple other cells to throw into the mix here. Here's the ILC2 cell, which is a real potent way to upregulate a lot of these T2 cytokines. It can clearly interact with the cystinooleucotrienes. It can produce a lot of important T2 cytokines you see listed here, IL-5 and IL-13. And then an interesting observation a few years ago was that a lot of the leukotriene production could actually be generated by platelets that adhere to polymorphonuclear cells. So the PMNs are not able to make cystinooleucotrienes on their own, neither are the platelets, but the PMNs have the first half of what's necessary and the platelets have the second half of what's necessary. And so when the platelets adhere to the PMN, they are now able to create a tremendous amount of leukotrienes, and that's been demonstrated to be an important mechanism in AERD. The final thing I just want to touch on is LTE4. LTE4 does not act at the same receptors as LTC4 and D4. It was, for many years, just viewed as a stable terminal mediator of the production of the cystinooleucotrienes, but now is known to have its own receptor, now known as the CystLT3 receptor. and have its own action, making this potentially a very important cytokine, specifically in AERD, where we know these levels are very high. As we're going through, I forgot to mention, please feel free to interrupt me if you have questions. I'm happy to entertain those. And at the end, maybe we'll have a little bit of a discussion if we have time. So for the mechanism of why aspirin therapy is effective, this really gets back to what are the dominant mediators, that question that I just asked. This was a study that Katie Cahill did, who's now at Vanderbilt. And this is a study looking at patients that were AERD at baseline, then looking at AERD on high-dose aspirin, patients that had aspirin-tolerant asthma at baseline, and then those patients also went on high-dose aspirin, where you would not expect them to get clinical benefit. So we're thinking the benefit of high-dose aspirin therapy is really going to rest here in the AERD patients. And what they looked at were, the effects on these T2 biomarkers. Some of the things that happened were paradoxical. So in patients on aspirin, their eosinophil count actually increased. Their tryptase increased. So these are going the wrong direction of what you would think for something that has an anti-inflammatory effect. What they did see that showed improvement was this really big drop here in PGD. And, that's a pharmacological effect here. You see it happening in the patients that were aspirin tolerant. It's expected because that's the effect of a COX-1 inhibitor, same here with thromboxane. But potentially, this is one of the dominant mechanisms for the benefit of aspirin therapy. And I'm going to show you a slide later, other work that shows that prostaglandin D is probably a very important mediator in AERD. And so potentially just by decreasing that, you can get therapeutic benefit. We still don't know the benefit of aspirin therapy, but this is an interesting way to think about it. Okay, so why should we try to diagnose and care about our AERD patients? I think one real clear answer to that is these patients do worse. In every study that looks at this, they have a harder disease course, higher relapse, and worse disease. So these are just a few take-home points. In most of the cases that I can find of patients that have really aggressive polyp formation, they're always in AERD patients. This is a patient who had intracranial nasal polyposis. This is a patient of mine. We're not accustomed to looking at these images, but this is a polyp that actually had extended from the nasal passage out the eustachian tube and had ruptured through the tympanic membrane. So you could actually see polyps when you did the ear exam. I've had a patient that had proptosis and had polyp that had ruptured into the orbit. So these patients can have very, very severe disease. And that's reflected here with the need for surgery. So in the pre-biologic era, these patients would have as many as 10 times as many surgeries when compared with their non-AERD counterparts. We know that they also have significantly higher rates of polyp recurrence at 6 months, which raised the question of futility after they've had 6, 7, 8 sinus surgeries. Is that really going to give them meaningful benefit if they're having that degree of recurrence at 6 months? Because this is a unified airway, we definitely would see some of that reflected here in asthma as well. These patients are more likely to have persistent airflow limitation. The Tenor study showed that in patients with severe asthma, there was a higher level of AERD. Some other studies have showed that your likelihood of being intubated for asthma was higher. Your need for systemic steroids was higher. And back before we had great controller therapy, at least in the Scripps cohort, a fifth to almost a half required daily prednisone to control their asthma. And I think this is why I'm passionate, why you should hopefully be passionate about AERD, is they have this miserable trajectory. They get surgery, they feel well for a short period of time, their disease starts to come back, and so we give steroid bursts, it helps. I drew this line here where potentially the patient has anosmia, so once their disease worsens, they lose their sense of smell here. You may be able to get it back temporarily with the steroid burst, but things are just moving in the wrong direction. And a lot of patients will tell you that as their sinus disease worsens, their asthma worsens. You would then get to a point, potentially over the course of 3 or 4 years, where things are now clearly out of control. They get surgery, and then the cycle repeats again. And this is really a horrible way for these patients to live. I just bring this one slide up. This has been looked at in a few different studies. We tend to think of AERD as being a very homogeneous group. They're all the same as each other. They all have the exact same disease. And I think in some ways that's reasonable. They have a very similar, endotype mechanism. But even when you look at AERD, you can really tease out some different groups. And so this was a latent class analysis that was done almost 10 years ago now. But they were able to look at patients that ended up really having a different disease course. So this class 1 had much more upper airway disease. Class 2 had pretty mild disease, more likely to be male. And so you can just see that not all AERD patients really are going to behave the same way. They may have a different disease course. And I wanted to bring this up as we go through the talk. We'll talk towards the end a little bit more about therapy, but I keep referring to aspirin therapy. And so, this is a hard disease to study in terms of aspirin therapy, because you have to, by definition, desensitize these patients up front. And some patients might not be willing to do that. In a crossover study, the patients actually would need to be desensitized twice. One time they'd get aspirin therapy, the other time they'd get placebo. And so you can see just by the nature of this that these are small numbers here. When we look across these are the randomized double-blinded trials that were done. Doses of aspirin, you can see here in general, the high dose, which is what we use when we put patients on therapy. And then if you look in terms of outcomes, all of these studies showed an improvement in sinusitis with a little bit more of a variable effect on asthma. And I would say that this is really where it seems like the dominant effect is on sinus disease, and the asthma probably follows as a consequence of improvement in the upper airway. So how common is AERD? What's the likelihood of finding an AERD patient? I think some think that this is an extremely rare condition, and you may not find it much in your career. But I think it turns out that it's a lot more common. And part of the point of me giving this talk is I want to raise your awareness to be thinking about this. So I want you to think, pull a number, or you could type into the chat here, take a stand. What's the prevalence you would say in the asthma population or in the polyp population? What would you say? So I don't think I can say see the chat here, but I'll give you a chance to take a stand. All right. Anyone holler one out or type one in?
All's quiet right now.
All right. Hopefully you took a stand here. So I'm going to go over what I think the best reflection of that number is, but we have to take into consideration these are hard studies to do, because who's going to find or look hard for AERD? Well, you may look at a specialty center, and we're obviously going to find more patients that are referred to us at Scripps than maybe a different place that doesn't see a lot of AERD. If you're just looking at history and patients telling you, yeah, I think I had asthma 10 years ago when I took an ibuprofen, that's very different than doing a challenge, right? And so we looked at this very carefully and decided that we couldn't just mix all of the different studies together. So we looked at questionnaire studies that we thought were fairly accurate way of asking. We looked at retrospective chart review that were based on physician interview. We looked at patients that had more severe asthma. And what we found in general, probably between 5 to 7% of our general asthmatics have AERD. If you look at challenge studies, you can see that that number goes up, and in severe asthma, that number is higher as well. So this means that some of the patients don't know that they have it. If you actually challenge them, they may react, but because they don't take NSAIDs frequently, they would say that they don't have a problem. And also, as we look in these population of severe asthmatics, we're going to see much more likely. I would think that in general, this is more common than people think. My gestalt is that people sometimes think it's less than 1% or very, very rare. Now, there is one really interesting exception. I like to call this out just because this is one of the better studies that's been done looking at prevalence. This was a Chinese study, and they took patients, 309 of them had nasal polyps, and they put them all through an aspirin challenge. And only 2 patients had it positive, which was only 0.57%. So probably 10 to 20-fold lower prevalence than we would expect if we did that same study in the US. And as you probably are aware, there's now several studies that show that the inflammatory makeup of polyps is actually different in different parts of the world. And in China specifically, there's a lot less Th2 or T2 bias, suggesting that potentially that could be a reason why we don't see the same prevalence in China. Okay, so if we're going to say that somewhere between 5 to 10% of our asthmatic patients and nasal polyp patients have AERD, then how do we find them? Do we challenge all of them, or can we use history? And these are I think the historical clues that you can use. And this is going to be coming out in the upcoming drug allergy parameter with some ways that we can use history to diagnose AERD without going to challenge. So on the top here, it says proceed to aspirin desensitization, but this is really just reflecting that if you are having that conversation and you're thinking about aspirin desensitization, you don't need to do a challenge first. You can assume that these patients have AERD. So the things that you would look at would be a reaction to 2 or more different NSAIDs. So someone who tells you they've reacted similarly to ibuprofen and aspirin, for example. We know that if you look at patients who take an NSAID and get hospitalized or have to go to the ER because of how severe the reaction is, 100% of those patients will have a positive aspirin challenge. You want the symptoms to be typical, so upper and lower airway, and short-lived. This will separate it from potentially like a viral-induced exacerbation. And then you really want these patients to have an underlying background of severe nasal polyps. And so if we look at the opposite here, these are patients where you're going to be uncertain and you should consider a challenge. So they've only ever reacted to one NSAID. You may not feel confident that that's really reflecting a reaction, a true reaction. They just have minor symptoms. Potentially there's an alternative explanation. If their symptoms are atypical, you'd really want to consider doing a challenge. And if you find out that, sure, they have some sinus disease, but it's really been very mild and easy to control for the last 10 years, would argue a little bit against AERD. So I think you can see if you end up here on this right side of the column with enough of these, you're going to feel real confident that your patient has AERD even before you do a challenge. But how do we do a challenge? So here's 3 ways that have been reported. I think most folks are using either the 90-minute variation on this or the ketorolac and aspirin. For 90 minutes, you're starting at roughly 1/4 to 1/2 of a baby aspirin, and every 90 minutes, you're roughly doubling the dose until the patient reacts. For the ketorolac, the idea behind here is you're able to do a local nasal challenge and potentially have less bronchospasm. So this is how it's done. If you are interested in learning more, just you can email me offline. This was our protocol. And then UT Southwestern actually published this, a faster protocol, with the idea that you could try to get through it, really in one day. For most of these, one other real important point is, what's the difference between a challenge and a desensitization? The difference really is what your intention is with the procedure. If your intention is just to identify whether they have AERD, then you stop once they react and you're done. You're not going to continue to go on. If your intention is to desensitize them, then once they react, instead of stopping, you repeat the dose and continue on. So for most of these, you can get the challenge done in one day, because as soon as they react, you'll just treat them and then you're done. But for desensitizing, what happens is somewhere along the line here, the patient reacts. And if they react in a way that requires a few hours of monitoring or therapy, you can see how it might start making your last dose end up being far enough towards the end of the day that you're not going to want to, give them another dose at 4:30 p.m. on a work day when the nurses and the clinic staff are leaving in half an hour. So for a lot of these, even though it looks like it's in one day here, a lot of times the patients end up coming back the second day, and we just by routine have done that in our clinic. Then patients are usually done by 10 or 11 the next day. Okay, so we're saying that, the history is pretty good, but it's not perfect. So you do an aspirin challenge, and then that's 100% diagnostic. You can tell by the way I'm asking the question that that's probably not true. And so this is a gentleman, I think that it illustrates the point. He had a history of requiring polyps removal every 3 years, and he'd had 7 surgeries by the time he had come to see me. He was on these meds. He can't drink alcohol because he'll get stuffiness. But he was told at the very beginning of his illness never to take an NSAID, and so he never did. He got some sort of IV pain medicine 3 years ago, but we don't really know for sure. He did not have a reaction to it. He had pretty significant airway obstruction, elevated exhaled nitric oxide. So I thought this gentleman very, very likely had AERD. So we had him come in, and the plan was just to go straight to a desensitization. We unfortunately did not get much of a reaction. He had a little bit of nasal congestion. We do nasal inspiratory flow, which didn't really change much. It was all very subtle, and we didn't treat him. So I was really uncertain as what to do with this. I still thought it was more likely that he had AERD, but maybe we had not seen it during our challenge and desensitization. And so we did what some people do. We said, well, you're desensitized, theoretically desensitized. So let's just try you on aspirin and see if you would notice any benefit. And a month later, he came back and said he feels like he's on prednisone. And we do a SNOT-22 score, which is a quality of life measurement that's commonly used in sinus disease. And so you can see the time that we did the challenge, his SNOT-22 score was 53. Lots of 4 out of 5 problems here with his a lot of ear symptoms, lots of drip. His sense of smell was completely gone. And now, about a month later, when we had him do this on aspirin, marked improvement in his SNOT-22 score. So this patient very likely has AERD. We just missed it on the challenge. And so what's been happening over the years, we back in the 70s and 80s, when AERD was really in its infancy, a lot of the challenges would end up with very, very severe reactions. Occasionally, some would end near intubation. But over time, the protocols improved. We started to add leukotriene modifier drugs because this has a real important role in protecting the lower airway from a lot of bronchospasm. And then by the time I started to really be doing this a lot, we had this protocol where the patients would be on a leukotriene modifier drug like montelukast. We'd put them all on ICS-LABA, make sure their asthma is very stable going into it. And this definitely seems to work well to really prevent a lot of these severe reactions. And we had the question early on, what would happen if is it possible that maybe the montelukast and all the medicines would just block the reaction from happening entirely? So two important things on this slide. First is the importance of montelukast. And so this is just looking at the amount of drop in FEV1. And you can see that if you are not on a leukotriene modifier drug, much higher rate of having a big drop in FEV1 during the aspirin desensitization. Whereas if you're on the leukotriene modifier drug, much lower amounts. It's shifted here down. So you're much more likely if you're on a leukotriene modifier drug to have just a small drop in your FEV1. And what we did not see was more negative challenges. That was one of the things we were interested in. Were we going to see a lot more patients with no symptoms? And we didn't. Now, this was not a randomized study. This was just an observational, retrospective analysis. And we think that probably what happens is the patients who came to us on montelukast probably stayed on it because it offered them some benefit, and probably because they had AERD. So it was sort of enriched for AERD. We see the same thing here. I'm going to skip over that slide. So we weren't thinking that we would really be able to block these reactions. But then this study showed that if you took 10 patients and you did 2 challenges, one of them on montelukast, the other one off of montelukast, you can see a difference. So you can see that the symptoms are diminished. So patients had less problems with asthma, but one of the patients had no reaction at all to the second challenge. And we clearly know this patient has AERD because they had had a positive challenge 2 weeks beforehand. So in certain circumstances, the montelukast might be able to block that reaction. In a small case series, this has been looked at where we took 6 patients that had an initial negative challenge and then subsequently repeated the challenge by changing the parameters a little bit with withdrawing the montelukast or giving them a higher starting dose of aspirin, and then they reacted. So, these are small numbers, and I know we're dealing with, your AERD patients, which are probably, just a handful in your clinic. But this is important because some of these patients, if you tell them they do not have AERD and then the circumstances change in their health a few years later, and they may take an NSAID thinking that they're not going to react to it, and they could, and that's actually happened in one of my own patients. Now, this is an interesting study just to underscore the potential effect of the montelukast. This is a nasal provocation challenge, which is done in a lot of other countries. We don't have lysine aspirin in the US to use. This is a Mexican study. And you can see that about half the patients converted from a positive challenge to a negative challenge when they were on a leukotriene modifier drug. So I think there's no question at this point that that some of our patients, if we do the challenge on montelukast, could have a silent challenge or a negative challenge, but still have AERD. The problem is if you just do your challenge initially without the leukotriene modifier on board, you do run the risk of having a higher level of bronchospasm and a bigger drop in FEV1. All right, and then finally, to make things even more complicated, this was a study that came from Alina Gershaw when she was at Montefiore, and they looked at patients pre and post sinus surgery. And I think your impression maybe would be like mine, that really shouldn't make that much of a difference. Why would having your polyps removed have any bearing on whether you'd react to an NSAID? But it turns out that if you look at pre and post surgery, these patients are actually generating less prostaglandin D metabolite. And then once you do the challenge so this is at baseline, and then during the challenge, you can see a tremendous elevation in prostaglandin D metabolite that doesn't seem to occur nearly as much in patients after sinus surgery, really arguing that a lot of the fuel for the reaction is actually sitting in the sinuses. And when they have sinus surgery, you're removing that. If you looked at the outcomes of the challenge, when it was done 3 or 4 weeks after surgery, a third of the patients no longer reacted. And so if you can think about that again in terms of the challenge, you might do an aspirin challenge in a patient who's had a recent polypectomy and you're pretty sure they have AERD, but it's all negative. And it doesn't mean they don't, it just means that right at the moment they're not reacting because their polyp burden is low. We tried to get at this in a study we did a few years ago. We were looking at the reaction severity and correlating it with baseline patient characteristics. And there really wasn't much that showed up except their SNOT-22 score. The worse their sinus disease is, the more likely they are going to have a severe reaction. And I think that may reflect a little bit how much of their polyp disease is present. So I guess that's just one of the take-home points is if you're doing a challenge, think about the proximity to surgery, and if it's negative and you're pretty sure the patient has AERD, you might want to consider keeping that diagnostic label on or reconsidering it as they go forward. All right, so what about the patients who say, well, I'm already taking a baby aspirin. How could I have AERD? I don't react to that. This is a case series looking at 6 patients where that was the story. They had a history that made the investigators think that they likely had AERD. And so they actually removed the aspirin for a few weeks and then challenged them. And these 6 patients all had a clear positive challenge. So they did have AERD. Somewhere along the line, either they had taken a baby aspirin and had a reaction and didn't really appreciate it, or potentially they started the aspirin before their disease began. But one way or the other, they were all reactive. And so just by being on a low-dose baby aspirin, it shouldn't steer you away from thinking that the patient could have AERD. And this is important because we know that at least some patients will react to a higher dose. If they're only taking a baby aspirin a day and then decide to take 800 of ibuprofen, they could actually react to that dose. You're only fully desensitized when you're at 325 milligrams. So let's go back to my patient that I presented at the beginning. So remember, she had told me that she could take NSAIDs without difficulty for joint pain. But when I asked her a little bit more about this, it turns out that she's a very avid soccer player and was having a lot of issues with musculoskeletal pain. And so she was probably taking her NSAIDs at least every other day, if not every day. And so I thought it's possible that she had somehow desensitized herself along the way. So we had her stop all of her NSAIDs for 2 weeks. We had her come in for a nasal ketorolac challenge, and she clearly reacted. She had wheezing. She had a small drop in her FEV1, not enough that we would call that significant, and also had clear symptoms. So we felt confident that she had AERD because she was going to plan to have sinus surgery. She had that first, and then we had her come back to do the desensitization. And interestingly, during her desensitization, she had the same reaction to the ketorolac, but as we pushed up the aspirin dose, she had pretty significant abdominal pain with vomiting. So this is actually not just an NSAID-induced gastritis. This is a true reaction that's occurring. So this is something that those of us who have done a lot of aspirin challenges and desensitizations have seen enough times that we knew that there was something unusual going on. When Katie Cahill was at Brigham, the Brigham group published this in 2014, where they looked at a series of patients that had severe gastrointestinal pain and also flushing during their desensitization. These patients are pretty uncomfortable, and it was very difficult to desensitize them, partly because the symptoms would last so long. They may have 3 or 4 or 5 hours of abdominal pain, and you couldn't really continue to go on. So they were able to look, though, at baseline and then during the reaction. And it's really interesting what they saw, that basically they could not suppress the prostanoids at the same level. So when you give a patient with AERD aspirin, you're triggering a reaction. The reaction is happening because mast cells and eosinophils are releasing their T2 mediators, including prostaglandin. So it's being produced as part of the reaction. But at the same time, what's aspirin doing? Aspirin is at the same time as it's causing this elevation of PGD2, its pharmacological action is to block it. So I view it sort of as like a teeter-totter in terms of which side wins out. And it seems like in this group of patients with these GI reactions, the strong high PGD2 elevation wins out, and it goes up way before the pharmacological action of aspirin is able to sort of take over and bring it back down again. Now, we've been able to desensitize these patients, but they're pretty uncomfortable. And going into it, I usually would have to go over with them, this is probably going to be reproducible if this is in their history. So, but think about this, especially if a patient tells you that, they have polyps, but when they took ibuprofen, they had horrible abdominal pain. You might be tempted just to think that they had gastritis, but this could actually have been their reaction. All right, so if I go through some of the pitfalls, I think some patients could have a silent desensitization or a silent challenge. We definitely know that patients, when they're on montelukast, if you ask them, are you allergic to ibuprofen, or do you have problems when you take aspirin? They may actually recognize they get nasal congestion or sneezing, but they don't even think that that really counts. So asking them very specific questions. When's the last time you took aspirin? When's the last time you took ibuprofen? Tell me about it. Tell me about how you felt. We know patients that are taking baby aspirin can have AERD. We discussed that these severe GI symptoms, it actually might be their AERD reaction. And if you do a challenge or desensitization right after sinus surgery, about a third of the patients could have a negative challenge. All right, so how do we do a better job at diagnosing AERD? What are the things that we can hone in on? So one of the things is alcohol reactivity. This is such a fun topic. It's such an odd thing that almost all AERD patients experience this, where they get nasal congestion or wheezing with alcohol. It does happen, as you can see here, in patients with aspirin-tolerant asthma and sinus disease, but twice as likely in the AERD group. And we don't really know why that is. It's not because there's COX-1 inhibition from alcohol. It's interesting because it's very quick. A lot of patients, about a third of patients, will have this within 15 minutes, and half of them it's just with a few sips. It really doesn't take much. It's bothersome enough that 3/4 of the patients will either reduce or quit alcohol entirely. And I can say confidently that this doesn't have anything to do with COX-1, because in AERD, when you desensitize them, although a lot of patients will have improvement, you can see here 37% of patients are still having alcohol reactivity despite being fully desensitized to aspirin. So we don't really know exactly what's going on here. It's probably a good marker of AERD, and I'd encourage you to ask those questions with your patients. This is a study looking at the intensity of their imaging findings. And so if you look at, this is a Lund-Mackay score where each sinus is given a score of 0, 1, or 2, 2 meaning it's completely opacified. So the higher the score here, the more the opacification. And this was at UVA, where they did challenges in these patients, and then they looked back and correlated it with their CT score. And so you can see patients with aspirin-tolerant asthma had a much lower Lund-Mackay score. Patients with AERD had a much higher Lund-Mackay score. And you can see as you start to get up to this level where they are completely opacified in all of their sinuses, these patients have a much higher likelihood of AERDs, 80–90% likely to have AERD. So I would encourage you, when you see a sinus patient, actually personally look at the images yourself, because there's something to be said for, seeing complete opacification versus reading a report that says pansinusitis, because pansinusitis could also just mean that they've got mucosal thickening in all their sinuses, right? But not complete opacification. All right, so here's the things I look at. I look at their CT score, I look at their need for surgery and their polyp regrowth rate. I look at alcohol reactions, I look at how much their sense of smell is impaired. And I also think about some other comorbid conditions when I'm trying to increase my suspicion of AERD. So interestingly, we see higher rates of esophageal eosinophilia in patients with AERD. This was described as a leukotriene rash. This is a rash, an urticarial type of eruption during an NSAID ingestion. There's interestingly a higher number of patients that describe having coronary vasospasm in AERD. And then in patients, in women patients, about a quarter of women with AERD will have premenstrual asthma. So these are some other factors. It's really not diagnostic of AERD, but that would, I think, raise raise your suspicion, put another couple checks in the box to look a little harder if the patients are describing these phenomena. We had recognized a couple years ago that we don't have a good way to measure the nasal reaction. We have FEV1 to measure the lower reaction. And so this is a real simple device if you're interested in doing these challenges. It's a peak nasal inspiratory flow meter. It's basically the opposite of the peak flow we use for asthma. So rather than exhaling into it, they just breathe in through their nose. And we were able to show that a drop in 25% of this peak nasal inspiratory flow had a really good positive predictive value for a reaction. All right, so let's just talk for a few minutes about treatment. Here's the landscape, I think, of what we have to offer our patients. Many of these are not well studied in AERD or are not FDA approved. And so that also, creates a lot of limitation. I think you're probably all familiar with a lot of the top part here. We use xylutone in AERD as another way of blocking the cystinuria-leukotriene pathway. I'll mention diet just at the very end. We have aspirin therapy after desensitization, which I've talked a bit about. We've got surgery. And then we now have 6 biologics that are available for use depending on the indication, either for asthma and then some of them for nasal polyps. So I'm just going to touch on a little bit of the studies that I think are interesting to review. For AERD, Dr. Taniguchi, who's in Japan, has a big AERD cohort and had placed 21 of their patients on omalizumab. So this is omalizumab in patients with known AERD, and then they looked at some of their metabolites, and you can see that on omalizumab there was a significant drop in their LTE4 level, their prostaglandin D level, their eosinophil level, and then improvement in a lot of clinical outcomes. It was really suggested that omalizumab could have a beneficial role in treating our patients with AERD. They did a follow-on study just published 2 years ago. This was looking at aspirin challenges on omalizumab. And so this is a crossover study. Each patient was their own control. One of the challenges, aspirin challenges, was done on omalizumab. The other was done on placebo. And what they showed is that the mediators that they're measuring were largely blocked on omalizumab. Both here, the top is looking at LTE4 and the bottom is looking at prostaglandin D metabolite. And a significant number of these patients had complete blockage of the reaction on omalizumab. So this really underscores the potential value of omalizumab, both in the long-term therapy of AERD patients and also in blocking these reactions. This was a similar study looking at the effect of omalizumab on aspirin challenges. 33 subjects, these patients were on omalizumab for 24 weeks. They had an aspirin challenge at baseline and then at 24 weeks. And about half the group had complete aspirin tolerance, so no longer reacted. And then 18% of the people who reacted, they reacted to a higher dose than what they did initially. So another study showing the effect of omalizumab on aspirin reactivity. Now, when we look at the other biologics, what we're really stuck with are really just pulling out the AERD patients that are self-described in the registry trials. And so this is just looking at AERD patients in the dupilumab studies, and really just showing that they get benefit just like the patients that don't have AERD. But we're not really specifically having a study that's designed to look at AERD. Small case series here looking at mepolizumab in patients that were started on this for asthma, and looking at their sinus outcomes, seeing that they do have improvement in several of their sinus outcomes. This was a large study looking at comparing the effectiveness of various therapies in AERD. And I'd encourage you to check this out if you're interested. It really goes through all of the different products. Here we've got aspirin therapy, we've got several of the biologics. It's limited really by the size of the studies looking at aspirin, the fact that these biologics weren't really designed to study AERD, so you're just pulling out some of the data. But it does give a starting point as we think about looking at these various therapies in terms of their relative effectiveness. Now, just to finish up here to talk about aspirin, comparing it with biologics. So we, I think, all recognize the value of biologics in our severe nasal polyp population. This is a large study that came out of the University of Pennsylvania, where John Basso is working with their rhinology group, and 103 patients that underwent FES surgery and then aspirin therapy. And they looked at their patients and followed them closely. And by 6 months, only 2 patients had need to go on to a T2 biologic. And so, they're really advocating that even in the face of these biologics that we have available, that aspirin therapy can still be a very effective treatment, potentially a more cost-effective therapy. We'll see. And then finally, talking about diet, this is a real interesting study from Tanya Laidlaw at Brigham, looking at a very high omega-3 and a low omega-6. And what this really does is starve the system in AERD for the precursors for the leukotrienes. And they were able to show actually on this pretty aggressive diet that patients could have improvement in symptoms and improvement in their asthma quality of life, as well as the improvement in their some of the mediators that they measured. So here's my final slide here. We may have 1 or 2 minutes for discussion. I think AERD is less common than 20%, but still, more common than you think. It's definitely out there. Maybe 5 to 10% of your patients in your practice have this. You can't completely diagnose it with history, but you can come close if you ask the right questions. I think it's very important that we identify these patients because they have a high burden of illness. They have some unique characteristics, and the biologic therapy is really a potential disruptor for how we have approached these patients in the past. But I still think we've got a lot more work to do to understand the best way to put the best places to put aspirin therapy, surgery, and the biologics. And so here are my questions. If we have time or someone wants to chat, type in some answers here. Why would you say it matters to diagnose AERD in today's biologic world? Should we just, we've got great biologic tools. Is that the way that we should be going here? And then my second question is, what about sinus surgery? Should most of these patients get a sinus surgery to debulk them before going on with another therapy? So I'd be curious, actually, if you have an opinion on that. There's not a right or wrong answer here. I'm not really fishing for anything. And I'll leave it at that if anyone has any questions.
So I've got a chat comment. Early diagnosis means earlier treatment and better patient outcomes.
Yeah, I definitely agree with that. There is some evidence that after your 3rd or 4th surgery, if you're not getting your sense of smell back, it's probably not going to come back. So especially when we think about that's a very important sense for some of our patients, right?
So I would throw out, once diagnosis is made, treatment, obviously there's some benefit of using the biologics that we have, but there's a cost associated factor that's huge. Most of us don't remain with the same insurance and approved drug the rest of our life, so things will change. So if you go through aspirin desensitization, that's a relatively cost-effective way to do things for life, assuming you don't have any complications from treatment.
Yeah, that's right. I mean, it's a great discussion because, not everyone is going to be a great candidate, and people will do aspirin and have side effects for sure. But you also could make the case to at least identify those patients up front, and if you're a great aspirin responder, it's, let's figure that out up front before we, put you on a lifetime of a biologic. So, yeah, it's a really, really interesting question about how that's going to all sort out.
So my comment on the sinus surgery should I think that depends on their quality of life and the load that they have and the response to the treatment. One of the slides you mentioned talked about the individuals with the greater load of polyps had a lot more mediators. So if you can debulk and lead to improved quality of life, it has the potential that obviously makes sense to have sinus surgery. Where I have the problem is I've had a young teenager who's had 3 sinus surgeries already. And what's his endpoint, and still a growing individual.
Yeah, that's a great. I mean, it's interesting because I think one of the other dilemmas is that patients, especially to an allergist, we end up seeing them at all phases of their illness, right? Like you'll see a patient that you identify their polyps first, right? And then you may see a patient who's had 8 surgeries and the ENT is asking for your help, and then you're seeing a big spread in the middle, right? You may see someone who, the tough ones I think are someone who's maybe like your patient who's had a few surgeries, has some recurrent disease. You could make the case to go back to the OR, but you're not really sure, and then is this the time to launch a biologic? So I think that's part of the challenge is the patients don't just come into us with like a very clear path. They're like sort of on this continuum somewhere along the way.
Okay. I think for sake of time here, I'll just one more question if anybody has it in the audience. Again, all's quiet. So Andrew, thanks for being here today. I've learned quite a bit and been through many of these presentations before, and it's fantastic that I continue to get more information and get to learn again. So thank you for being here, contributing to COLA, and I hope to see you again in the near future.